definition that make kind of more sense in the way they see this syndrome. It's there is Bongaze and colleague proposed the model, the cardiorenal connection, as an addition to the hemodynamic framework. So on this cardiorenal connection, there is two section or two part of that. So there is the hemodynamic changes, and there is also the cardiorenal connection. And they propose the renin-angiotensin-aldosterone system, the RAS, and they propose also the balance between nitric oxide and reactive oxygen species. These are they have pro-vasodilatory effect. They propose also inflammation, sympathetic nervous system as a circuit within the cardiorenal connection. So le dérangement of any connector was thought to initiate a vicious downward spiral culminating in disturbance in the other connector and culminating in cardiac and renal dysfunction through common pathway. So any dysfunction of this connection, any problem in this connection can induce the cardiorenal syndrome. So this classification, there is five stages, five type of cardiorenal syndrome, but I will concentrate mostly in this talk about type 1 and type 2. So type 1, when you have an acute cardiorenal syndrome, it's an acute cardiac impairment leading to acute kidney injury. And you see that in cardiogenic shock and acute kidney injury, acute decompensating heart failure resulting in acute kidney injury. Type 2, when you have chronic cardiorenal syndrome and causing impairment to the kidney and inducing chronic kidney disease. So you see that in patients who have chronic systolic or chronic diastolic congestive heart failure, and they cause chronic change in the kidney, chronic kidney disease. Type 3, you call it acute renal cardiac. So type 3, type 4, it's an acute, type 3, the acute kidney injury leading to cardiac impairment. You see that in people who develop acute kidney injury, for example, they become anuric. They stop making urine, and the patient becomes fluid overloaded. Even though patient has good ejection fraction and good cardiac function, still they will be fluid overloaded. So they call this type 3 acute renal cardiac. You see it also people with glomerulonephritis, with diffuse inflammation like lupus nephritis, and those mediators can cause depression of the myocardium and can induce to low cardiac output and congestive heart failure. Type 4, when you have chronic renal cardiac, it's a chronic kidney disease leading to cardiac impairment. There is what we call chronic kidney disease associated cardiomyopathy that was described, and this is due to myocardial remodeling and fibrosis. Type 5, it's secondary cardiorenal syndrome when you have systemic condition leading to both cardiac and renal impairment, such as diabetes, amyloidosis, and sepsis. So the pathophysiology, if you on the right side of your screen, there is I took this from the Clinical Journal of American Society of Nephrology, and this is the pathophysiology of acute decompensated heart failure. So in the acute decompensated heart failure, low output cardiac failure, you have reduced cardiac output, and you have an arterial underfilling. So you have decreased forward output. So in the high output cardiac failure will be the same systemic arterial vasodilatation, such as, for example, people with liver cirrhosis, they have this reduced arterial underfilling. So when you have reduced arterial underfilling, you have activation of the sympathetic nervous system, and the sympathetic nervous system will activate the renin-angiotensin-aldosterone system. The arterial underfilling also, it will activate the renin-angiotensin-aldosterone system. Then you have also secretion of vasopressin. You have release of vasopressin, and all these factors, the result, you will have diminished renal hemodynamic and renal function, and you have also increased sodium. You have increased sodium and water reabsorption and increased sodium and water excretion. So that's that one. On the left side, you have the pathophysiology of cardiorenal syndrome. So for example, if you go to low output failure, cardiac failure. So you have decreased cardiac output, and you have that arterial underfilling. When you have arterial underfilling, you have the connector, the cardiorenal connection, as we described earlier, and you have neurohormonal, you have activation of neurohormonal mechanism, increase or activation of sympathetic nervous system, the RAS activation, and the production of vasopressin. For as far as the kidney concern, you're going to see vasoconstriction because you have activation of renin, angiotensin, aldosterone system, and activation of sympathetic nervous system. You have the vasoconstriction, reduced perfusion, reduced GFR. You have increased proximal tubular reabsorption of sodium and water, and you have also very interesting phenomena that we can discuss later on. And you have decreased distal sodium and water delivery. And you have what we call impaired escape from aldosterone and resistance to natriuretic peptide. And I will discuss later on about this impaired escape to aldosterone. So usually normal I will discuss it in another slide, I think. But so you have also what we have in chronic congestive heart failure, or even in acute congestive heart failure. You have the depressed baroreceptor. So the baroreceptor, they have an inhibitory effect on the sympathetic system, but because of the underfilling, that arterial underfilling, so the baroreceptor will be depressed, and you have also decreased fullness of the arterial circulation. So that's so here you have the role of this decreased baroreceptor sensitivity and activation of RAS and sympathetic nervous system when you have expansion of water and sodium retention and heart failure. So if you see in chronic cardiac failure, you have decreased baroreceptor sensitivity on chronic basis. So that what happened, there is the inhibitory effect. You don't see the inhibitory effect of the baroreceptor on the sympathetic system and on the RAS system. So you're going to see an activation of sympathetic and RAS system, and that will cause proximal tubular and sodium and water reabsorption. And you can also see there is what we call decreased distal sodium and water delivery, because one of the reasons of this is failure to escape from aldosterone. Okay. So let me explain this a little bit more. So if you have, let's say, if you have patient or you inject patient with aldosterone, you give him high dose of aldosterone, or you have an hyperaldosterone state. So what happened? You have decreased excretion of sodium, water and sodium, and that sodium and water will be reabsorbed. So then in hyperaldosteronism, or patient that you inject with aldosterone, you will never see edema. So the sodium will be high, and they have tendency to retain water, but there is no described edema in this patient. The edema you see it in congestive heart failure patient. And the reason is that when you have hyperaldosteronism alone, without activation of the sympathetic system, without congestive heart failure, what happens is that the hypervolemia that result, that will the hypervolemia, and once the patient start having normal sodium intake, so that salt and water will be delivered to the distal nephron and the collecting duct. So then the sodium and water will be excreted. So this is why you're not going to have the edema. So this is normal mechanism that you see is not normal. You see it in people who are producing high aldosterone, but they have this escape mechanism. In this way, they will retain salt, but in the water, they can still be able to deliver that water to the distal tubule and the distal nephron, and the water will be excreted. But in patients with congestive heart failure or cardiorenal syndrome, you cannot do that because the GFR is reduced and the renal perfusion is reduced, and you have activation, or you have increase sodium reabsorption in the proximal tubule. And so this is very interesting mechanism. So in a congestive heart failure patient or cardiorenal syndrome, you have failure to escape from aldosterone. So you don't have that. You have also resistance to natriuretic peptide. So if there is no distal delivery of salt and water to the distal nephron and to the collecting tube, the natriuretic peptide will act on the distal tubule, is not going to have any effect, but because there is nothing there. So the patient will become resistant, kind of, even though patient is producing the natriuretic peptide, but there is no effect on the water and fluid excretion. So all these lead to sodium or water retention and cause increased cardiac filling pressure. There is also a mediator that's been released. There's interleukin 1, interleukin 6 that can cause downstream cardiodepressant effect on the myocardium. And there is also what we call uremic cardiomyopathy. You see it in type 4, this one. And okay, so this one is just another summary of the pathophysiology of the acute heart failure. So acute heart failure, you have the hemodynamic mediated damage that we discussed, and also you have, and that causes decreased perfusion, increased venous pressure, and that can cause acute renal injury. You have also another pathway if you are using too much diuretic, and also the use of ACE inhibitor in congestive heart failure may lead to acute kidney injury. And there is also vasoconstriction. There is the humoral signaling and endothelial activation, cytokine secretion. So they all contribute. For the chronic heart disease, you have a low cardiac output, you have inflammation, you have arterial calcification, endothelial calcification, and this lead to initiation of kidney damage. Then with time, you're going to have chronic hypoperfusion, increased venous pressure, increased venous resistance, and will induce progression to chronic kidney disease. There is also mediator in chronic heart disease, mediator like the interleukin 1 that can cause sclerosis of the muscle and that of the cardiac muscle, and that can cause sclerosis of the heart and the kidney. So what is the best marker for renal impairment in cardiorenal syndrome? Is it the cardiac index? Is it the central venous pressure? Is it the pulmonary capillary wedge pressure? Is it the systolic blood pressure? So this is the best. What's the best marker for renal impairment? So
pour te répondre au chat, Rachid.
Yeah.
Pour ta question.
Okay, I'm sorry. Yeah. Quel est le marqueur? Quel est le
in English, no problem. They will on the chat. You will have les réponses sur le chat.
Okay. No, I'm just asking question, but I'm going to explain.
Okay.
Yeah. I'm going to explain. So I will explain now. Okay. So the best marker of renal impairment, it's a CVP. It's not the cardiac.
Question. Quel est le meilleur marqueur?
Quel est le meilleur marqueur du cardiorenal syndrome?
C'est une question.
Pour l'insuffisance rénale, quel est le marqueur qui va indiquer qu'un malade avec une congestive heart failure va développer une insuffisance rénale?
Et tu poses une question.
I'm sorry, Dr. Professor.
Tu es en train de poser une question.
Yeah, no, je suis en train de poser une question.
Il va apporter les réponses.
To myself et de l'audience, mais je vais répondre.
Très bien, vas-y.
Yeah, I will explain the data that it's just for me and for l'audience, just to ask them. They don't have to respond, they just ask me. Yeah. So, quel est le meilleur marqueur qui va nous indiquer qu'un malade avec une congestive heart failure va développer risque de développer une insuffisance rénale? So c'est le CVP. So the central venous pressure, and I'm going to show you why. So there is an abstract. This was published in Journal of American College of Cardiology, and they look at the importance of venous congestion for worsening of renal function in advanced decompensated heart failure. So هذا un papier ils ont essayé de déterminer les facteurs qui déterminent qu'un malade est prone de développer une insuffisance rénale once he develops congestive heart failure. So abstract. So the objective is to determine whether venous congestion, la congestion venous, rather than the impairment of the cardiac output, is primarily associated with development of worsening renal function in patients with advanced congestive heart failure. So the background, so usually, on pense que le cardiac output, c'est le déterminant qui va déterminer qu'un malade a plus de risque de développer une insuffisance rénale. So that's the background. But so the method, they took 145 consecutive patients qui ont été admis avec une acute congestive heart failure, and they treated with intensive medical therapy guided by pulmonary artery catheter were studied. And so we define the l'insuffisance rénale, the acute l'insuffisance rénale, as an increase of serum creatinine of more than 0.3 milligram per deciliter during hospitalization. So what they found, the summary of the study, that venous congestion is the most important hemodynamic factor driving the acute kidney injury in decompensated patient with advanced heart failure. And I'm going to show you more about the result of this study on the following day. So here, so if you see on the left one, on the CVP, so on this side you have worsening renal function. So if you have a CVP less than 8, so your risk of having renal failure is probably around maybe 8%. So if the CVP between 8 to 16, the risk is a little bit higher. 16 to 24, you see is higher. If the CVP more than 24, the risk of developing acute kidney injury or insuffisance renal is almost 80%. If you use the systolic blood pressure, so systolic blood pressure less than 90 compared to systolic blood pressure 95 to 110 to 110 to 125 or more than 125, the risk is the same, is about maybe 30%. If you go to the pulmonary pressure, the fourth one, the pulmonary capillary wedge pressure, you see the same between, so if you see less than 20, 20 to 26, 26 to 32, more than 32, the risk is approximately like 35%. Now, if you go higher to the second one on your right, you can see the cardiac index. So less than 1.4 milliliter per minute, so 20%. But when you go to cardiac index of more than 126, the risk will be like 50%. So now how we are going to interpret this data? Does the cardiac index has still, it's one of the most important indicator of developing acute renal failure, or is it only CVP? Is it both? So let's compare them. Let's try to compare both of them in a graph and see what happened. So then, if you see then on the red line, the red line is CVP, the sensitivity and the specificity of the CVP, it's more than the cardiac index in stratifying the risk of patient developing acute kidney injury once they have the congestive heart failure. But look at this now. So these are the CVP at discharge. So you stabilize the patient, you treat them with IV diuretic or ultrafiltration or anything, then you discharge them. Then you follow this patient and you will see who are the patient who developed acute kidney injury. So if you can see, so if you can go to high CVP and high CVP with high cardiac output and low cardiac output. So the one that has a high CVP is a high CVP, the risk of having worsening GFR is higher. So you have a GFR of between 60 to 40. Once you have high CVP, and you plug low cardiac output or high cardiac output, and you can see. Now, if you go to low CVP, the first part of the graph, you have low CVP and low CVP, and you add high cardiac output and low cardiac output, you will see, so the GFR is higher regardless of the cardiac output. But if you have low CVP, the GFR is higher. You can see the GFR is higher with low CVP, even with the high cardiac output or low cardiac output. But if you see with cardiac output, if the cardiac output is high or low, regardless of the cardiac output, once the CVP is high, you have the risk of having a low GFR. It's more pronounced with high CVP than high cardiac output. That's in post-analysis of the ESCAPE trial, very good trial, this one, it's evaluation study of congestive heart failure and pulmonary arterial catheterization effectiveness. We're going to discuss more about this trial. And so the right atrial pressure was the only hemodynamic parameter associated with baseline renal dysfunction. So in this trial, it's a large trial, so they were looking at different parameters, and the only connection that they were able to make with patient developing worsening renal failure is the right atrial pressure, and that will tell you that the vascular congestion is the central venous pressure and the right atrial pressure. Consequence of prolonged contraction of the right ventricle. So, and that when you have when you have a high pressure in the right ventricle, so the right ventricle, there is an extramural force that push the septum that between right and left ventricle, and push it toward the left ventricle, and that will increase the left ventricle and diastolic filling pressure. And you can see this paradoxical septal movement from the right to the left. That's because of the vascular congestion, and that's because of an increased pressure in the right atrium. And once you have reduced left ventricular and diastolic filling, you're going to have reduced forward output, and then we will go to the pathway of the arterial underfilling. And that one, the arterial underfilling, trigger the neurohormonal response with the sympathetic activation, RAS activation, vasopressin production, and other mediator. So now, let's go now to diagnosis evaluation of cardiorenal syndrome. There is a biomarker, and as you know, there is a troponin is a biomarker for myocardial injury. Biomarker wall tension, it's a BNP and a pro-BNP. This is well established. There is a biomarker of acute kidney injury. Many biomarkers, they're now emerging. We don't use them. We use some of them, but most of them, they are being used in research, in place where they do research or academic institution. So the definition of an acute kidney injury in current use depend on change in creatinine or urine output. So one of the problem with how you define acute kidney injury, and one of the need to find better biomarker is that when the creatinine, before you see the change of creatinine, the change of creatinine happen 24 to 48 hours after the patient is in acute kidney injury. And so sometimes you lose that window of opportunity when you have when you need to reduce the dose of diuretic or do something else, or maybe stop the ACE inhibitor or angiotensin receptor blocker. So then the creatinine also has some problem. Sometimes it overestimate or underestimate the kidney function for different reasons that I will explain later on. So there is a marker that we use, cysteine C. It's a cysteine protease. It's found in all nucleated cell, and it's produced as constant rate, freely filtered, not like the serum creatinine, not like the creatinine. It's not freely filtered. It has a distal reabsorption. It's completely reabsorbed and not secreted in the renal tubule. So the creatinine is secreted in the renal tubule. Some of it is being secreted in the renal tubule. So in a subset of patients with chronic heart failure in the cardiovascular health study, the highest quartile of serum cysteine more than 1.55 was associated with twice the risk of cardiovascular mortality. So the cysteine C can be used to evaluate, to stratify patient with chronic heart failure. And you can see if the level is high, more than 155. So in patient presenting with acute heart failure, serum cysteine was a strong indicator of re-hospitalization and short and long-term mortality. These are marker of renal tubular marker. There is one we call the NGAL, neutrophil gelatinase associated lipocalin, and it's secreted by renal tubular epithelium and myocardial cell. The NGAL is the most upregulated protein produced by the kidney in the setting of acute kidney injury. In meta-analysis of 10 studies that involved 2,000 patients with predominant cardiorenal syndrome identified, so early serum and urine NGAL measurement are predictor of need for dialysis. So on those 2,000 patients, they were able to test for the NGAL in the serum and the urine. They did serial testing, and they found that when they saw that the curve was going upward, they were able to predict. They came up with this formula. They were able to predict the need for dialysis. So this is it. So it has been used as a research tool, but in some limited place they use it. And so serial measurement of NGAL in acute heart failure increase is predictive value for acute kidney injury. So these are here. Here there is different marker. So if you so we discussed cysteine C, albuminuria. You know that's a marker of glomerular damage, and we discussed about the NGAL and. So basically this also the interleukin 18. The cardiac marker, there is the troponin, the cardiac troponin. It's a marker of myocardial injury, and it has diagnostic value in cardiorenal syndrome and also in acute coronary syndrome. BNP, marker myocardial stress, and the ST2, it's a marker. It's been used in one institution not far from us. They use this marker. I'm going to discuss a little bit about it. It's a member of IL-1 family of receptor, and it's been used in the heart failure and cardiorenal syndrome. There's another marker also. It's been used, galactin 3, and so these are the recommendation class A1 recommendation that from 2017 of the American Heart Association, and the recommendation for the use of BNP in its inactive cleavage pro-BNP in the diagnosis and exclusion of heart failure, as well as establishing prognosis and quantifying severity in acute heart failure and chronic heart failure. So the ST2 and galactin 3, as I told you, there is an institution not far from us that they use this marker. So ST2, it's a protein that you can find in the cell lining of the left ventricle and the aortic outflow tract in response to biomechanical strain. So that this STL2 result in myocyte dysfunction and tissue fibrosis. So if you have chronic kidney disease and elevated ST2 on chronic basis, the patient may end up having fibrosis and a further cardiac problem. So the ST2 measurement offer incremental value to natriuretic peptide level in predicting heart failure related death and hospitalization, and they are not affected by renal function. As you know, the troponin is been affected by renal function and some of the BNP. So the galactin 3, it's another protein synthesized by cardiac macrophage, and it's an independent predictor of cardiovascular mortality. In one of the study that was done is called the Corona trial, and they found They found that patient was galectin 3 level increased by more than 15% over 3 to 6 months, had significantly increased adjusted risk for all-cause mortality and hospitalization for heart failure. Diagnostic evaluation, the volume assessment, as you know, there is the chest X-ray. Chest X-ray will allow you to see if the patient has congestive heart failure, the cardiomegaly, pleural effusion, thoracic ultrasound, bedside. You can give you an idea about the fluid status, the good physical examination, edema, GVD, ST3, echocardiogram, especially to evaluate the inferior vena cava and the absence of collapse with respiration, and we do it bedside. And there is another test that we don't use, but describe. You can inject the patient with isotope tracer, and it will tell you about the volume of fluid. There is one easy to use. We use it twice. We did study in the renal patient. We use this one. It's measuring the conduction of the water in the patient. And so we use an electrode, is a bioimpedance. We use an electrode, and that you can connect to the wrist and to the foot. Then this electrode will give you measurement. So it will give you different vector. So the water is a good conduction media. It will conduct the water. So if you have too much water in your system, the conduction will be fast. So the vector will be shorter. So if you can see on the lower, on this hydrogram, you can see that going lower. I'm not sure if you see my hand, but that's the vector toward the anasarca. It's a shorter. So the speed and the conduction of the water is shorter. So the vector is shorter. So that tells you that the patient has anasarca or is fluid overload. And if the vector is going to the opposite side and longer compared to the other one, so that tells you that it's slow. The conduction is slow, so there is not much water. Then there is the normal number that they choose. That's 73%. So that 73% is the 50 percentile. It's not the 73 percentile, but they choose this 50 percentile, and then you can, according to where the vector is going, it will tell you if. But this is just it's not really accurate. But I think on my practice, when I see the patient, I do good clinical exam. Most of the time, a good clinical exam will help me understand. And sometimes I examine even the back of the patient. Sometimes when I'm not sure and things, I will see their back, and you can see fluid there. And I look for edema, GVD, look at the chest X-ray. Sometimes we do bedside echocardiogram. It's available here when we can do it. The cardiology does it. The nephrologist also, they do it. So that and will help you understand more and decide about what to do. And so this just there is no need to go through this for the impedance. There is another device that we use that has been used. We don't use, but has been used. There is a trial called Champion Trial, and what they did, they did cardiac catheterization, right-sided cardiac catheterization of the patient, and they implanted a device in the implanted device that device sent data, wireless data, concerning the PA pressure. So they were guiding their treatment according to that device, according to the PA pressure. So for example, if PA pressure was high, so the doctor who's checking the data every few days, they check it. So they were deciding if to give more diuretic or less diuretic or add vasodilator. So, and the study showed that lower hospitalization rate and trend toward lower mortality in 456 patients with heart failure with reduced ejection fraction in the group who were being monitored, who the PA pressure was being monitored. But only few people use it. It's not common here. We don't use it here. but it's a study that was done, but it's not practical. You have to do cardiac catheterization, and you have to do an implant, put implant there, and so it's not. There is another one. There's Medtronic. They did a study called Optivol. When they put an implant, transthoracic implant, and they measure the transthoracic fluid measurement and the pulmonary fluid status. And again, this through wireless connection, and this was given data to the physician, and they were deciding about when to change the diuretic. So reduction in outpatient visit for heart failure symptom or hospitalization admission with the use of device alert has not been demonstrated. So the benefit was not great, but it showed to have prognostic value in heart failure. So specific data on outcome with cardiorenal syndrome using implantable intrathoracic impedance measurement are currently lacking. So in this treatment strategy, so I want to just go, if you go on the right side and you see the BNP, and we are talking about the biomarker, the role of biomarker. So for example, when you have a patient with congestive heart failure, the BNP is high, and then you are diuresing him, and you are not sure the patient is hypotensive, blood pressure is in low range, and creatinine, no change in the creatinine, and not sure what to do. Or if there is change in the creatinine, not sure what to do. So if you use a marker, this biomarker that we discussed, especially the NGAL, so it's at the early stage of acute kidney injury. And also it doesn't have to be at early stage. If you take serial measurement and you see that the NGAL level is getting higher, it's the same than PSA. So the PSA can be normal, but if you take serial measurement, every year the PSA is higher by 0.3 or so that tells you there's a problem. Maybe there's prostate cancer or something, even though it's normal. So the NGLL, even though it's in the normal range, but doing serial measure and following those numbers that tell you that if it's getting higher, that tell you that the patient is in early stage of acute kidney injury. So maybe at that time you can catch the patient, you can maybe give him less diuretic, or maybe stop the diuretic, or maybe stop the ACE inhibitor, add vasodilator, or at least think about it. Think that the patient, that he is developing acute kidney injury. And as we discussed previously, there is a strong association between kidney and heart. And you can see on the curve, the lag of creatinine. So it will take 1 to 2 days before you see the rise of the serum creatinine. Okay, so how to treat congestive heart failure? So loop diuretic cause inhibition of the sodium potassium 2 chloride channel ascending loop of Henle, and it causes natriuresis and volume loss. It's a short duration, 2 to 3 hours IV, and up to 6 hour PO. Oral furosemide has 50% bioavailability. This one is not 50%. I think oral furosemide, it has, we're going to see another slide, it has some data say that 30 to 50% bioavailability. So intravenous administration and subcutaneous infusion. Some center, I didn't see it. We use IV or PO, but I found there is some center, apparently they use subcutaneous infusion of furosemide, and this will have 100% bioavailability. Torsemide has a longer half-life and require less frequent dosing. Torsemide, it's proximal loop diuretic, like the furosemide. Torsemide may be more effective as decongestive therapy compared with furosemide. Several small study and meta-analysis show that. So when we have patient with acute kidney injury, congestive heart failure, we diurese them. We use mostly IV, Lasix IV. Then when we switch them, I switch them to torsemide. I feel more comfortable with torsemide because it's long acting and the half-life is longer, and also because of this. So if you can see the bioavailability of the furosemide in this study, say 10 to 100. So if you give patient 100 milligram of furosemide PO, patient who has vascular congestion, edema in the bowel, and with high CVP, and so you can either, maybe the patient is absorbing 10 milligram, maybe he's absorbing 100 milligram, you don't know, because the bioavailability. The torsemide, if PO, it's 80 to 100. In other data, the other data that I have, it's a 70 to 100. You give him 100 milligram, you know that at least in this data, 80 milligram will be absorbed and it will have an effect. So this is why I use more, in our team, use more torsemide than furosemide. The same apply to BMX. It has very good bioavailability, 80 to 100. And so the relative potency, a lot of things, many people, they ask about how, when we switch to IV to PO, what's the equivalence? So the potency between furosemide, torsemide, and BMX, so you have 40 PO furosemide, 20 torsemide PO, 1 milligram BMX. IV between Lasix and PO Lasix. So if you have, for example, 40 milligram of IV Lasix, so the PO conversion is 80 milligram. So the 80 milligram. Torsemide, if you have 20 IV, is 20 PO. BMX, if you have 1 milligram IV, it's 1 milligram PO. So drug half-life. So you can see another benefit of torsemide. It's 3 to 4 hours. So the half-life is 3 to 4 hours. Furosemide 1.5 to 2, and BMX 1 to 1.5. Duration of effect, torsemide 6 to 16 hours compared to furosemide 6 to 8 and BMX 4 to 6. So can you imagine those patients with congestive heart failure and maybe not compliant, taking a lot of medication, and you ask them to take the furosemide twice or 3 times a day versus giving them a good dose of torsemide once a day. So this one, this is the mechanism by which negative sodium and water balance may improve myocardial and renal function in congestive heart failure. So this is the role of negative balance in those patients. So when you have congestive heart failure, you are using loop diuretic of ultrafiltration treatment. You have negative sodium and water balance. So what you are going to do, that will result in decreased cardiac filling pressure. So like we discussed earlier, when you have positive balance, positive sodium and water balance, you have high CVP, high atrial pressure, and increase ventricular pressure of the right ventricle, and that will cause paradoxical motion of the septum, paradoxical movement, and increase the pressure of the left ventricle and lower the filling pressure of the left ventricle, and that will induce low cardiac output and underfilling. That if you have the left problem, on the left the same. If you have a high filling pressure, you will have high left ventricular pressure, and that will cause the same problem. So what you are going to do, you're going to decrease the cardiac filling pressure. Once you decrease the cardiac filling pressure, you're going to decrease the ventricular dilatation. And when you do that, you are going to decrease ventricular wall stress and undo myocardial ischemia. What you are going to do also, decrease functional mitral insufficiency. I did not discuss about the mitral insufficiency. I thought I will not have time, but the mitral insufficiency, it's one of the prognostic factor of the cardiorenal syndrome. And it has also, it will tell you that patient with severe functional mitral insufficiency, their volume, they have a high CVP, they are congested, and they are the one who will probably develop acute kidney injury. So this, beside the CVP, the functional mitral insufficiency. So you're going to decrease the functional mitral insufficiency, then you're going to improve myocardial function and improve renal function. So that's so now there is issue when you treat patient with diuretic. There is certain problem that so in some patient you need to increase the threshold for diuretic. So you need I'm sorry, there is what you call increased threshold for diuretic effect. So that means that you need to increase the dose. You give the patient diuretic, then you don't see response and what to do. So the cause of the patient requiring more diuretic not responding to the dose that you give him is here. Number one, delayed intestinal absorption. Many of those patients, they have their bowel are swollen, they have water. So you are not going to have good absorption. There is decreased renal perfusion, increased distribution of volume, and altered tubular secretion, acute kidney injury, or chronic kidney disease. So in this case, what you do, you switch from, maybe increase the dose of PO, furosemide, or switch from PO to IV. Or what we do, once the patient is on IV, and I feel that he's not responding, I will keep him on 80 twice a day, and I will give him bolus in between. I'll give him a bolus of 40 or 80, and that's one of the things. Or you give him continuous IV infusion. And I will discuss about the bolus versus continuous IV infusion. So this one, the diuretic concentration in the tubular fluid is reduced. And the other problem that may happen, you may have plateau. So you are giving appropriate dose for the patient, but it reach plateau, and so that's you feel that the diuretic are not working anymore. So that's one of the reasons that maybe the patient is dry, maybe the renal, you have severe vasoconstriction and not enough flow going to the proximal tubule where you have the sodium and the reabsorption of sodium and water. So there is nothing going. The diuretic are not going to the renal tubule. So there is no effect because of vasoconstriction. So renal response to the volume depletion. There is post-diuretic rebound effect and late breaking effect. So post-diuretic rebound effect, when most of the time when you give patient IV diuretic, so you will be, so there is a, let's say you give him furosemide. So you're going, the furosemide act on the proximal tubule. So you're going to block the reabsorption of salt and water in the proximal tubule. So that fluid, whatever fluid, will go to the distal tubule. So some of that fluid will be reabsorbed in the distal tubule and some of it in the collecting tubule. So with time, let's say patient is a few days, congestive heart failure, IV Lasix, with time, what happened? In the distal tubule, you are going to have rebound phenomena. So once the fluid and sodium arrive to the distal tubule will be avid and will be avid to reabsorb the sodium, and that you'll be absorbing. Late breaking, there is early breaking and late breaking. So late breaking, that when the patient has chronic congestive heart failure, they are on diuretic all the time, and they're, for example, taking Lasix. Then with time, they're going to develop distal cell hypertrophy. Distal cell hypertrophy because the distal loop and the distal nephron will be avid to reabsorb that sodium and water. Then they will develop an autonomous function, like someone with secondary, someone with hyperparathyroidism, primary hyper, they have their own autonomic function. So what you do in that case, and here they say repeat dose over 24 hours, continuous IV infusion. I will go with 3 sequential nephron blockade. So the best response to this is that you need to block. You are blocking the proximal tubule. You give them Lasix or you give them torsemide. Then you block the distal tubule. You use distal loop diuretic such as metolazone. It's a long-acting, or chlorthalidone, or we use mostly metolazone. You can block also the collecting tube. You can use spironolactone. So you are going to block the reabsorption of sodium and water in different area where the sodium and water are prone to be reabsorbed. So that's so here this is a diuretic optimization strategy. C'est une comparaison between dose diuretic, PO and IV at different doses, and discuss about the result. So this is an evaluation of various diuretic strategy, loop diuretic, for patients with acute decompensated heart failure for 72 hours. So they choose first one, low dose, for example, 40 milligram. of Lasix, and it was given IV Q12. Then they choose the same dose, 40 milligram, and they give it continuous infusion. So 40 milligram, they choose this one 80 milligram. So one dose, but they give it as 80 milligram because they want to do Q12, 80 milligram and infusion. On the high dose, they took 2.5, the oral dose, and they give it Q12. Then they took 2.5, the oral dose, and they give it IV infusion. And the finding, there was no statistically significant difference in global symptom relief or change in renal function at 72 hours for either. So Q12 dosing or intravenous infusion, low dose or high dose. High intensification oral dose was associated with a trend toward greater improvement in multiple domain, symptom relief, weight loss, and net volume loss. And it also helped the sign of congestion, and it reduced the natriuretic peptide. So this will tell you that good treatment with PO, with the PO Lasix or torsemide can control the symptom of congestive heart failure with also education, low sodium diet, and all that. So there's another study that was done, is called the DAOUI acute heart failure, where they took loop diuretic Lasix in acute heart failure, and they gave the patient IV, and other patients, they gave them continuous dosing, the continuous infusion, and they did not see any difference in mortality. So this study, this ROSE acute heart failure, renal optimization strategy evaluation in acute heart failure. So this the kidney tubular injury detected by biomarker did not appear to have an association with worsening renal function in the context of aggressive diuresis of individual with heart failure. So this study, and we'll go further, and I'm sorry. Those diureses have an effect on RAS activation. When you give the patient IV Lasix, is it going to increase or activate further the RAS system? And this is a follow-up analysis of dose acute heart failure and CARES heart failure. High dose loop diuretic therapy did not result in RAS activation greater than that with low dose diuretic therapy. So if you give high dose diuretic therapy, you can, if patient need high dose, you give him high dose, and ultrafiltration resulted in greater increase in plasma renin activity than stepwise pharmacological intervention. And we are going to discuss in the next slide. Diuretic resistance is due to all of the above: reduced GFR, breaking phenomena, and we are going to review this: post-diuretic sodium retention, tubular compensatory sodium retention, all of the above. So this is what happened when you have diuretic resistance. And I'm repeating myself on the previous slide, but this will summarize what I was saying. So first, you have diminished oral bioavailability. Then the second thing that can happen is impaired delivery of the drug to the renal tubule. The third one is impaired sodium delivery. And the other one is breaking phenomena. And we're going to discuss all this. So first, diminished oral bioavailability of the drug. So outpatient therapy, oral bioavailability is the first line of resistance. So heart failure and food intake can prolong time to peak concentration and the peak drug level. If you see, at least on the US, when you read about furosemide, they don't tell you that you need to take it on empty stomach. So they don't. But if you take the furosemide on empty stomach, it will prolong the time of peak concentration and the peak drug level, and you're going to have less effect. So if you patient take it, we tell them to take it on empty stomach. The other problem is that 95% of protein is protein bound. So hypoalbuminemia increase the volume of distribution and reduce the availability of loop diuretic for facilitated diffusion. So either patient has less albumin, for example, liver cirrhosis, when they come fluid overloaded. So we give them diuretic and things. For myself, when I see liver cirrhosis, I will try few days, we diurese them. If it's not working, I will stop and I will speak with the team and I will tell them just maybe those patients need paracentesis on regular basis instead of doing diuretic and trying to do paracentesis every 2 months or so. Sometimes they need once a month and things, once a week or twice a week. And I stop using the diuretic because they don't have enough albumin. Their albumin level is very low, and so that's one of the reasons. And concerning the impaired sodium delivery, so in chronic kidney disease patient or in cardiorenal syndrome type 2, like we say, type 2, you have chronic heart failure causing chronic kidney disease. So there is reduction of the excretion of diuretic into the tubular lumen because of the low flow going to the kidney because of the chronic kidney disease, and that the diuretic induced sodium excretion is reduced in chronic kidney disease due to diminished filtrated load of sodium. So one of the things that we can do, administration of effective dose multiple times per day may help. Sometimes it may not help when you have acute kidney injury or no flow going to the kidney. You diurese them is not going to help. So heart failure result in increased expression of sodium, potassium 2-chloride channel requirement. So what happened also when you have heart failure, the sodium and potassium 2-chloride channel, the expression of this channel, they will be increased. So in this patient, and so that's why you need more dosing, and they will be increased. Why? Because of what we discussed, the hemodynamic changes and the neurohormonal changes will lead to the reabsorption of sodium and water, and with time you're going to have the patient with heart failure, they have more expression of this channel, the sodium chloride, the sodium potassium and 2-chloride channel. And diuretic resistance, braking phenomena. So braking phenomena is short-term and distal tubular hypertrophy long-term. So diminished diuretic efficacy with each dose. Every time you give patient, so there is less efficacy. You give him 40, then the following day you give him 40, and you see there is no effect, then you are going to increase the dose. And this is likely due to perceived distal sodium loss, resulting in upregulation proximal distal sodium transporter. So what happened once that when you give the patient diuretic, you are going to the patient is going to excrete that sodium and water. But what happened at the proximal level and the distal level, our body think that they are losing sodium at high. The loss of sodium will make the patient increase the production of this channel of the sodium potassium chloride channel at the proximal tubule and at the distal tubule, and they try to reabsorb that sodium. So that's one of the reasons. And there is data about low chloride that also play a role in activation of this channel. One more thing also, there is the late breaking phenomena. It's that when you have, it's a distal remodeling. When you have hypertrophy of the distal tubule, because the hypertrophy distal tubule, because of the reabsorption of sodium and water at the proximal level. So this is the late breaking phenomenon, and so that's one of the things. Ultrafiltration. So the one of the question about ultrafiltration. So I will show you all the data about ultrafiltration. So the data about ultrafiltration are not really, there is different data, and I will show you what I use. There is with ultrafiltration, there is less potassium wasting, less renin and aldosterone release, and increased sodium loss. There is passage, or it's a briefly passage of blood through semi-permeable membrane with external negative pressure applied and consequent isotonic fluid removal. So these are the different data. You can, I'm going to send this slide and this presentation to Professor Khadda, and I try to summarize all the data that are available and concerning the ultrafiltration. So there's different data, and I'm going to review two with you. So I'm going to review the end load data and the KRS data. And yeah, let me just talk about this. So the KRS heart failure. So this is ultrafiltration in decompensated heart failure with cardiorenal syndrome. So they took 188 patients with acute heart failure, worsening kidney function, and they randomized them to receive stepped pharmacologic therapy with IV diuretic versus ultrafiltration. So the finding that the use of stepped pharmacology therapy algorithm was superior to a strategy of ultrafiltration for the preservation of renal function at 96 hours with similar amount of weight loss with two approach. UF was associated with high rate of adverse event. So in this study, the goal of ultrafiltration, improvement of symptom was the same, but the risk of worsening kidney function was higher in patients who had ultrafiltration. This one say the opposite. So that's what I use when we, so ultrafiltration, this is ultrafiltration, the unload trial, ultrafiltration versus intravenous diuretic for patient hospitalized for acute heart failure. So the aim is to study the effectiveness of ultrafiltration versus aggressive loop diuretic in patient with acute heart failure. So ultrafiltration arm, so they want up to 500 milliliter per hour. So I use 250 to 300, but on this study they use 500 milliliter per hour, and volume and rate determined by clinician versus diuretic arm. Intravenous diuretic at least 2 times outpatient oral dose within 48 hours of randomization. So they give them high dose of IV versus ultrafiltration. Look at the finding. Early ultrafiltration produced greater weight and fluid loss than intravenous diuretic without adverse impact on kidney function. Early ultrafiltration reduced 90-day percentage of patients requiring rehospitalization for heart failure, number of rehospitalization, and day of rehospitalization of heart failure, emergency department, and unscheduled office visit. So the unload suggested superiority of ultrafiltration over diuretic in patient hospitalized for volume overload heart failure. So this, so that's what in our institution, and that's what I implemented to my team to use, and I discussed with them this study. But there is other study that they are in between, and my experience is that it will help removing large amount of fluid, and it will we don't see worsening kidney function, and we see short the length of hospitalization is shorter, the risk of readmission is shorter, and so that the risk of readmission it's less than if you use diuretic, and so that's one of the things. Okay, now let's talk briefly about neurohormonal modulation, vasopressin modulation. Does the vasopressin help, or natriuretic peptide help in managing the congestive heart failure? So on this study, on the Everest study, so what they did, they took patient with congestive heart failure with ejection fraction less than 40%, and they were hospitalized for worsening heart failure with sign and symptom of congestion, and they treated them with the tolvaptan, is the vasopressin antagonist, is the tolvaptan. So they treat them with tolvaptan, and then they follow them for 60 days, and this is the result. The conclusion: tolvaptan, in addition to standard therapy, improved sign and symptom of heart failure, but has no long-term effect on mortality or heart failure-related morbidity. So this one study. There is another study called the tactic heart failure, and this one here, and it showed the addition of tolvaptan to standardized furosemide regime did not improve the number of responders at 24 hours. And the conclusion, in patient hospitalized for acute heart failure, the addition of tolvaptan to diuretic did not improve the proportion of responder at 24 hours. The use of tolvaptan resulted in greater fluid and weight loss and trended toward greater dyspnea improvement at later time. No difference in clinical endpoint such as length of stay or post-discharge outcome up to 30 days. So when the company came up with tolvaptan, we used it in few patients, but it's very expensive and it doesn't improve the outcome of the patient. Even when you use a diuretic, good dose of diuretic versus tolvaptan, there is data. Diuretic, you can do well with diuretic without using tolvaptan. And like I told you, the one pill costs $60. So some people use it. The company came to our institution. They want us to use it, but we refuse. One of my partners used it. Then we reviewed data, and then we stopped using it because it didn't make sense. So that's the use of tolvaptan. Now the use of one of the questions that we always have: how about the inotrope use in cardiorenal syndrome? Oh, so these are a study that was done and showed, and yeah, let me show you this here. So this is the summary of the earliest of this one. So I'm going to tell you about some. So inotrope. So in post hoc analysis, differential effect of 72-hour cumulative urine volume in favor of dopamine in patient with ejection fraction less than 40% compared with nasiritide in patient with ejection of more than 40%. So patient who used dopamine, in 72 hours they had more urine output. They have more urine output, but the benefit, long-term benefit, was not there. So there is in some data using dopamine, even at low dose, using dopamine, was linked to increased cardiovascular outcome because of arrhythmia, ischemia, and worsening long-term myocardial ischemia. So even though it's 72 hours, you can see an improvement in the fluid status, but there is a risk that long-term data may not support the use of dopamine. But we use it. Cardiology in our institution, they use low-dose dopamine. Our nephrology team, we don't use it. Yeah, if we need to use something, we use diuretic mainly. And so there is in nasiritide, there is also no benefit in using nasiritide in those patients. So the RAS inhibition, okay. So I compiled this data mainly for cardiologists, and so just to discuss about the RAS inhibition, I will discuss later on about RAS inhibition in cardiorenal syndrome 2 and 4. But I want to review in heart failure, and on the left side, these are the data, almost all the major data about the benefit of ACE inhibitor, of RAS inhibition. So in 1987, consensus trial, it was the first trial to demonstrate mortality reduction using ACE inhibitor in heart failure. Then in 1992, the SOLVE trial, it was the first trial to show that ACE inhibitor reduced death or heart failure in asymptomatic systolic left ventricular dysfunction. 1999, Renal trial, first trial to demonstrate mortality reduction using the mineralocorticoid receptor antagonist like spironolactone in addition to ACE inhibitor. And 2014, Paradigm trial is the first trial to demonstrate mortality reduction using the ARNI instead of ACE inhibitor, and I'm going to discuss about this more. And so the RAS inhibitor in chronic kidney disease patient in the setting of cardiorenal syndrome, and you can see effect on ACE inhibitor on survival in congestive heart failure. So on the consensus trial in the New York Heart Association, class 4, with use of ACE inhibitor, reduce reduce the mortality rate, the risk of mortality by 40%. In class 2 to 3, reduce the mortality rate by 16% on the slide on the left. In this study, doubling of serum creatinine in 11% of subjects taking enalapril compared with those taking placebo. So 11% of this patient, they had doubling, their serum creatinine double compared to placebo. Serum creatinine rise were predominantly early, return to within 30% of baseline value in most subjects. On the SOLVE trial, it's an ACE inhibitor in heart failure from asymptomatic left ventricular dysfunction to severe heart failure. SOLVE trial, they have two arms. So if you are asymptomatic left ventricular dysfunction, 20% reduction of death or heart failure hospitalization, 29% of death or new heart failure. So you have reduction of 20% and 29% of death or new heart failure. In chronic heart failure, the mortality rate was reduced by 16%. So now if you use the ACE inhibitor in severe congestive heart failure, look at the benefit. Reduction of 40% of mortality in 6 months, 31% in 1 year, 27% at the end of the study. And the conclusion, the enalapril, so there is, on this study, the enalapril group. So on the SOLVE trial, serum creatinine was less than 2.5. The enalapril group, 33% had high likelihood of serum creatinine rise of 0.5, more than 0.5. But this is very important. If the audience, maybe if there is any message that I can give you today, is that look at this number. No progression of chronic kidney disease, end-stage renal disease, or doubling of creatinine was reported in this trial. So even though there is 33 of this patient, they develop their serum creatinine went increased by 0.5, but the long term, they did not see progression of chronic kidney disease, end-stage renal disease, or doubling of serum creatinine. And in post-hoc analysis of this trial, the SOLVE trial, with heart failure and chronic kidney disease, mortality benefit was even present in subjects with higher degree of chronic kidney disease. So that means that in congestive heart failure with chronic kidney disease patient who are taking ACE inhibitor, one of the initial reflex that we do, cardiologist does, nephrology, and this to stop the ACE inhibitor and give them diuretic, and so we usually we don't do that. We try to stop ACE inhibitor only if I see trend of the creatinine getting higher and worsening over a period of few days. But if they call me for consult patient with congestive heart failure and acute kidney injury, and he's on ACE inhibitor or angiotensin receptor blocker, so I will not stop unless they are really hyperkalemic or anuric. I will stop the ACE inhibitor, or I will hold, not stop, I will hold the ACE inhibitor, and only after a few days, if I see significant worsening of the kidney function, but the ACE inhibitor, if you use, that's in acute. And the same apply to chronic. The chronic kidney patient, chronic congestive heart failure with chronic kidney disease, usually I don't stop the ACE inhibitor unless they are around stage 5 or the end of stage 4. Stage 4 when GFR 16 to 19, GFR between 16 to 29, they're stage 4. So when they are at 20, less than 20%, and I see they start to be hyperkalemic, I will give them more diuretic, more medication to lower the potassium. Then when they go, but if they keep being hyperkalemic, I will stop the ACE or angiotensin receptor blocker. But if the kidney function worsen on the chronic basis and they are still on ACE inhibitor, I will not stop ACE inhibitor only if there is compelling reason, if there is severe hyperkalemia that I cannot control otherwise with other medication. So usually we don't stop ACE inhibitor, and the reason is this study, is the SOLVE study. So if you have a chance to review it, it's a very good study that was done, and you can see in post-analysis when they took CKD and heart failure and ACE inhibitor, mortality benefit was good, was still present in those patients with worsening kidney disease. And Administration of exogenous natriuretic peptide, the nesiritide. Does nesiritide has any benefit? So the nesiritide, there is a randomized control trial that was done and failed to improve primary outcome, which is to improve dyspnea. So that will, and there is also this. There is another thing, the neprilysin. The neprilysin, which is new. It's new. It's not new. The study was done in 2014. It's the neprilysin inhibit the breakdown of natriuretic peptide. So neprilysin is found in number of tissue, but especially in high concentration kidney. Natriuretic peptide are also cleared via the natriuretic peptide clearance. So what I'm going to show you, look here on this slide, very important thing. So if you can see, the neprilysin on the slide on the left, when the neprilysin, and you go to the yellow, when there is a yellow LCZ696. So next to it, the neprilysin. So the neprilysin, what it does, it will inhibit the metabolite, the active metabolite of the natriuretic peptide, the bradykinin, the substance P, and the angiotensin 1. So that's what it does. So and the benefit of that, if you inhibit, so on the normal thing, so you have this substance, the natriuretic peptide, for example, it will be degraded by the neprilysin. Then you will have inactive metabolite. So the natriuretic peptide, the bradykinin substance P, what they do, they cause vasodilatation. So this is a good thing for the body. For people with congestive heart failure, you have to have more of natriuretic peptide, more of bradykinin, more of substance P. So they cause vasodilatation. They increase they increase urine output. They increase the excretion of sodium. They cause vasodilatation and decrease myocardial remodeling. So then, if you block the naprilysin, if you block the naprilysin, if you block the effect of naprilysin, that means that you are going to increase the lifespan of a natriuretic peptide and the bradykinin and substance P in the system, and you will have more positive effect. So the study was done initially, and they tried to block the naprilysin. And what happened, it was not successful. Why is that? Because if you go next to the substance P, there is angiotensin 1. So the angiotensin 1, when you try to block the effect of the naprilysin, you are activating the effect of natriuretic peptide, but also the angiotensin 1. So the angiotensin 1 was hyperactivated, and it was staying in the system for a long period of time. That was activating the RAS system and was causing worsening congestive heart failure, despite the natriuretic peptide was higher. But so they didn't work, the initial stage. So what they did, they tried to block the angiotensin 1 conversion. So they add with the sacubitril, which this one that blocked it, they add an ACE inhibitor. What happened? It caused severe angioedema. So they stopped that combination. The last trial, what they did, they add an angiotensin receptor blocker, which is the valsartan, and now we call it Entresto in the US. So now with this Entresto, you block the effect of natriuretic, but also you block the effect of the angiotensin system, the RAS system, that conversion, and then you'll be activating the natriuretic peptide, the bradykinin substance P, and cause vasodilatation. And look what the result showed. So if you, on the Entresto, or the angiotensin receptor natriuretic inhibitor, or the ARNI, and these are the study you can view, but if you go to the right side of the screen and you go below, if you use an ARB, angiotensin receptor blocker, like DAOUI, and so the survival benefit of blocking the RAS system, you are going to reduce the mortality rate of patients with heart failure by 10%. If you use an ACE inhibitor, you are going to reduce that by 15%. If you block if you block the effect of naproxen inhibition and an ACE inhibitor and the angiotensin receptor blocker, like we show, you're going to reduce the mortality rate by 16%. So that means that you're going, so we are using an ARB and you are using the naproxen inhibitor. So there is significant reduction in the mortality rate of cardiac patient by 30%. So you can see you can go to 30% if you use this one. I'm not sure if in Algeria it's been used. I suspect it's been used, but we use it here, and it's called Entresto. Entresto, yeah. Meta-analysis that combine naproxen with RAS inhibition and versus RAS inhibition alone, and there is data from Empress study, and yeah. So that's, and I show you this data. When you block we use ACE, you use an ARB, angiotensin receptor, or you use a combination of naproxen and angiotensin receptor blocker, and that yeah. If you want to go back, you're going to find the data on the screen, and you can review them. But this one, to remember, it's 30% reduction of mortality if you do this. So that's one. The few slides left. So one is the composite and outcome of death or heart failure was reduced in patients receiving combined naproxen and angiotensin receptor blocker inhibition in all three trials that we discussed. Combination of naproxen and RAS inhibition compared with ACE inhibitor it was associated with more hypotension, but less renal dysfunction and hyperkalemia. So if you block the RAS system by using ACE or an ARB versus using naproxen and angiotensin receptor blocker, on the naproxen side, you see more hypotension, but less kidney dysfunction and less hyperkalemia. And there is a Paramu trial that was listed earlier, and it's a prospective comparison of the naproxen inhibition versus ARB or management of heart failure with preserved ejection fraction. And even on this trial, if you go back to it, these are patients. This trial is different in the way they use it in patients with preserved ejection fraction. The trial that I show you, that 30% reduction, is with diminished ejection fraction. But if you have preserved ejection fraction, you can reduce the blood pressure and atrial pressure while preserving the GFR. So the atrial pressure and the CVP, and when you reduce atrial pressure, you are reducing CVP with this combination beside the diuretic, and we saw that the CVP, it's one of the most important factors that give you an idea about people who are going to develop acute kidney injury when you have cardiorenal syndrome. So mineralocorticoid receptor antagonist, long-term efficacy of achieving complete suppression of RAS with ACE inhibitor ARB is limited, and phenomena of aldosterone escape result in an increased level of serum aldosterone. Mineralocorticoid receptor like spironolactone, when added to an ACE inhibitor on ARB, provide more suppression of RAS system with potential long-term cardiorenal effect. And when you block the mineralocorticoid receptor, what you have reduction in mortality and cardiovascular event in heart failure patient with low ejection fraction. And there is a study that was done called the RAL, randomized aldosterone evaluation study. And there is the efficacy study where they use the eplerenone in post-acute myocardial infarction. And most of the cardiac patients that we use with chronic kidney disease, we keep them on low dose of eplerenone, and we watch the potassium, but we try. But also we have to be careful using all this combination in advanced kidney disease patient that you may end up with the hyperkalemia. So you have to follow this patient, and you have to make sure that they do blood tests and they come to see you. You can't give them all this drug and they will go home and you see them in 1 year. And so the take home, it's a cardiorenal syndrome is pathophysiological condition, as we discussed about the hemodynamic changes and the cardiorenal connection. The treatment is to be individualized based on etiology. So every patient is different, and you see what you can use. You determine and decide, but it's not wrong to diurese the patient one day, 1 or 2 days. For example, I had a patient last week in Glensford Hospital. He came, he had 360 pound, 1 kilogram is 2.2 pounds. So you divide by 2.2, that will give you maybe 160 kilograms, something, full of fluid. And he has been getting fluid a long period of time, non-compliant. He had maybe 40 or 50 pound of water weight extra. So I diuresed him one day, and he did not make urine, and he's just sitting there. He has obstructive sleep apnea, pulmonary hypertension. So I knew this patient, if I keep diuresing him, it's not working, it's going to take a long time to help him, and he's going to be there for a long period of time. So the second or third day, I think the third day, we decide to put a line and to do ultrafiltration, and in a few days we are able to remove a lot of fluid on those patients. So early diagnosis is important for better survival, and so it will give you a chance. There is a tool when you can diagnose the patient early with like the NGIL marker that is being used in some institution, and that may tell you that there is acute kidney injury, and maybe you need to reevaluate and see what you can do, and maybe combination, like a coordination between nephrologists and cardiologists. So like cardiology and nephrology here in the hospital, we have our cell phone, all of us, and whoever is on call discuss with the. So there is a constant discussion between us about patient. And early diagnosis is important for better survival. Early novel marker are to be used in diagnosis. Each patient with either chronic kidney disease, cardiovascular disease, to be assessed with risk factor and follow-up. So this is just my intake of this, is that this is difficult, this topic, complicated topic. It's heart and kidney, they go together, and each patient will be individualized, and the treatment will be individualized instead of doing the same thing for all patients. We have to be careful how to use a diuretic. When the cardiologist, all the time this happen. Not in our institution, now is less, but before, when they cardiology call for patient with congestive heart failure, full of fluid. So the hospitalist, we have in the hospital system where all the patient, I used to admit renal patient in the hospital, but now we change the system and we have hospitalists. So there is doctor employed by the hospital, and they are internists. So they stay in the hospital and they admit all these patients, and they call for consult. So when those cardiac patients have been admitted with acute kidney injury, so the cardiologist and nephrologist and the hospital are involved. So before we see them, when they have acute kidney injury, bad congestive heart failure, most of the hospitalists, they used to stop the diuretic, and some doctor in the ER, they even give them fluid, and thinking that because of the acute kidney injury, or they're a little bit hypotensive. But we change the way people think. And I always tell them, I tell the cardiologist, and if you have patient with congestive heart failure, acute renal failure, you are not going to please the kidney. If you please the kidney, you're going to die with congestive heart failure. You can't breathe, you are huffing and puffing. So you diurese the patient, diurese them, give them whatever needed to control the CVP, control congestive heart failure. Then whatever happened to the kidney, you will deal with it. That will be part of the process. But you can't give fluid, or you can't hold the diuretic, and you know that the patient needs the diuretic, and you just wait and see what happened to the kidney. So the number one is take care of the symptom and relieve the congestive heart failure, improve the symptom. Ultrafiltration, we use it a lot. We have service called, we do plasmapheresis. We do plasmapheresis for other patients, but the same room where we do plasmapheresis for different pathology, not here, but we do ultrafiltration. So the same nurse trained to do dialysis, the acute dialysis, we train her to do ultrafiltration also, and we train her to do plasmapheresis. So this is what I can tell you. And so this one, references and acknowledgement. So I was able to get all the data from this. There is also another acknowledgement for Dr. Mahangali. He's an associate professor. I didn't have a chance to do it. Associate professor at Albany Medical Center, and I also use some of his slide, and it's not here because I had another presentation that I was going to present, but this morning I went to the hospital to round, and when I went back to my car, I did not find my computer. Maybe I left my car, or I didn't lock it, and maybe someone took my computer and the presentation, and so I had to scramble and do this presentation at the last minute. So that's why his name is not here, but he helped me with some of the data because they work with an academic institution. Assalamu alaikum. Shukran.
Thank you for this very nice presentation. سلام راسك. سلام راسك.
بارك الله فيكم.
لك برك الكمبيوتر معليش سي با غراف.
No, في data, في a lot of data that I have, but that's fine. معليش الحمد لله.
على باس الحمد لله.
الحمد لله.
Thank you for this very interesting presentation and very practical. A lot of message, and we have some questions. Il se fait un peu tard. German have several questions. Tricity, allez, vas-y, pose quelques questions, German.
First, I'd like to thank him for the level of the presentation. It was very, very interesting. The topic is very, very important for us, and the quality of your presentation is very, very, very high. It was really simple but very practical, and we have understand a lot of things. And you have acknowledged us about a lot of things. And the question that I want to ask you is about the use of thiazidics in your practice when the renal function is not is not severely impaired, because we have noticed that in the diuretic resistance, it can be a solution in the first at early stage, and it helps the patient to get better and to cover the diuresis. The second question is about the use of pyromere to manage the hyperkalemia. Do you use it? Third question: does the worsening of the renal function can it be a predictor of a factor to use the Entresto at early stage, at the initial hospitalization, as it was shown in Pioneer trial? There is a benefit to use Entresto in an early stage of heart failure when it's severe, and when we have renal impairment, because it's better supported by the kidney than ACE. And the last question is about the use of ultrafiltration. We have noticed that it was really benefit in our practice, but it's not really available. So how can we wait, or how can we convince our nephrologist to use it more frequently, because it's a kind of a deal to challenge to get a ultrafiltration in our department. That's all.
Shukran. So the first question is the use of distal loop diuretic, like chlorothiazide. Yeah. So in patient with normal kidney function, that's a great thing. And even patient with chronic kidney disease, because we want to block the proximal loop, which is Lasix, and you want to block also the distal loop, and you blocked by distal loop diuretic, which is the chlorthalidone or metolazone. I use the metolazone. But if the kidney function is fine, you can use chlor instead of the hydrochlorothiazide. Use the chlorthalidone, which has a longer half-life. So you do the sequential blocking. So with the Lasix, and if not responding, you block the distal loop by using the metolazone or hydrochlorothiazide or chlorthalidone. You can add also spironolactone to block the collecting tube. So that's you can do. So that's number one. Number two. One of the question you remember is the use of angiotensin receptor blocker instead of ACE inhibitor. Yes, I think in the chronic kidney disease patient, I use more ARB angiotensin receptor blocker than ACE inhibitor because of the risk of hyperkalemia. So then, but the benefit is the same, but you have less risk of hyperkalemia with angiotensin receptor blocker. And how to convince the nephrologist? I think if you review them data, I think they will. I'm sure they know this data. You just maybe having a discussion between your team and the nephrology team, and show them the data that I show you about the SOLVE trial. That when the kidney function, that you have decreased reduction in the mortality rate, even when the creatinine increase. And there is other data that show you even the creatinine increase, that's not the cause of the end-stage renal disease. So that number, when creatinine is high, does not lead to end-stage renal disease. Other parameter can lead to that. So the use of ACE inhibitor, angiotensin receptor blocker, that's very important. And the Valtasa, the hyperkalemia medication, yes, we use it. It's very expensive. I try to use it less. I use it with IV. I try to use a diuretic. But if I can't, and I want to keep the patient on ACE inhibitor, angiotensin receptor blocker, I use Valtasa. So that's these are the.
Thank you.
Shukran. Thank you.
Thank you.
Hello. Professor Makhada.
Okay. For me, it's okay. You have answered to my question. Thank you.
Barakallahu fi. Shukran. Thank you.
Jamal has a question. Jamal, you can. Bilal Jamal. Aya, pose ta question. Tu as posé plusieurs questions, Jamal. Jamal, est-ce que tu m'entends? Aya, Bilal. Vas-y.
So, Dr. Daoui, using the trilogy.
Oh là là. Arrange ton micro, arrange. Fixe the mic. Non, non. On t'entend pas. Jamal.
Renal impairment.
Oh là là là. Je t'entends pas bien.
Allô?
Non, non, t'entends pas bien, Jamal. Arrange ton micro.
Allô? Allô?
Voilà,
Ça va comme ça?
Ça va mieux.
Allô?
Oui, on t'entend. Ça va mieux. Pose ta question.
So, Dr. Daoui, we were talking about neprilysin.
Non, non.
Neprilysin and valsartan therapy.
Yeah.
We have what we call here Entresto. And when we're using it for the first time, in the titration phase, we have mild renal impairment. We have decreased renal function. So, are we expecting a recovery from that renal impairment or not?
Are we expecting recovery?
Of renal impairment.
Recovery from the renal impairment of neprilysin valsartan therapy.
Okay. Yeah. So so the Entresto, it was used to reduce the mortality rate in patients with a low ejection fraction. Ejection fraction and chronic kidney disease. So there is benefit because you are using an angiotensin receptor blocker, the valsartan, and there is strong data. You see them in other presentations that showed that ACE inhibitor and angiotensin receptor blocker can improve the kidney function or keep it stable for a long period of time, and it has a lot of benefit on the kidney. So there is the part of angiotensin receptor blocker. So you are not going to see a recovery of if there's chronic kidney disease, and especially if advanced, you're not going to see recovery, but it will. Any chronic kidney disease patient need to be on ACE inhibitor and angiotensin receptor blocker. So you are doing whatever you are supposed to do, but mainly the combination Entresto, it's for the reduced mortality rate in patient with low ejection fraction. But used in chronic kidney disease, yes, you need to use it because you need to use the angiotensin receptor in the chronic kidney disease anyway.
Okay, thank you. Nabil Ben Daoud, Professor Ben Daoud, you have a question?
Yes. Have you any experience for with the dapagliflozin or other SGLT2 for cardiorenal chronic syndrome with or without diabetes?
Okay. For for the GRDS and this ST2 inhibitor. So this new data showing that they have significant impact in lowering the cardiovascular mortality in patients with diabetes and cardiac condition. So we start using it. We start using just recently, but you have to be careful in patients with GFR less than 30 milliliter minute. So in some of the data, they say it's not advisable. You have also be careful with, they have diuretic effect. So if the patient has a chronic heart failure and they're taking diuretic, so they will increase, there's risk that the patient may become dehydrated. So maybe you need to reduce the dose of diuretic effect. But there is strong data showing that it will reduce the mortality rate, the cardiovascular complication when you use it in the right setting. But we start using it recently.
Okay.
Thank you.